The human eye operates within a strict mechanical constraint. It sits inside the orbit, a rigid, bony box with only a single opening. Because these bony walls cannot expand, any pathological increase in tissue volume inside this space follows the path of least resistance. It forces the globe forward, resulting in a physical protrusion known as proptosis. This brings us to a specific clinical presentation. A 30-year-old female arrives with a 2-week history of a red eye and a distinct, starry look. We measure her proptosis at 24 millimeters. A rapidly bulging red eye forces an immediate diagnostic calculation. We must determine if this is an autoimmune reaction, a local infection, or an aggressive neoplasm. The stakes for getting this wrong are severe. If left unchecked, the active inflammation can rapidly engulf the soft tissues of the eye. Beyond simple swelling, advancing pathology can push the globe entirely past the protective barrier of the eyelids, leaving the ocular surface dangerously exposed. To accurately identify and treat orbital disease, clinicians must deconstruct these visible surface symptoms to deduce the hidden pathology underneath and establish precisely how far along the disease progression we are. Differentiating orbital pathology is an exercise in mapping clinical signs against a strict biological timeline. Let's look at thyroid eye disease, or TED, which is governed by a strict biphasic timeline. We see a clear division between an active phase and a chronic phase. The first phase is the congestive stage, defined by acute inflammation and producing highly congested, red, and painful eyes with grittiness and excessive lacrimation. The first major indicator of this congestive phase is epibulbar hyperemia. We see an engorged, tortuous network of vessels expanding across the surface. When our patient described starry look, she identified lid retraction. Notice the abnormal exposure of the white sclera above the left iris. Here is a more severe bilateral example. The upper lids are pulled back by fibrotic or inflamed levator muscles, creating this pronounced staring expression. If this lid retraction is mild, it frequently improves spontaneously once the underlying hyperthyroidism is brought under control, requiring no direct surgical intervention. Eventually, the inflammation burns out, and the disease enters its second phase, the fibrotic or quiescent stage. During this fibrotic stage, the eye typically returns to a white and painless state. However, the patient is often left with permanent structural damage, such as a painless motility defect caused by restrictive myopathy. Because our patient presents with acute hyperemia, pain, and swelling, we can firmly lock her diagnosis into the active, congestive phase of thyroid eye disease. As the orbital soft tissues and extraocular muscles expand during TED, proptosis becomes the most visibly striking mechanical complication. This forward displacement is axial. It can manifest symmetrically or asymmetrically, and it frequently becomes permanent. The immediate physical danger here is mechanical. Severe proptosis compromises eyelid closure, triggering a cascade of exposure keratopathy, corneal ulceration, and eventually deep infection. But the most severe threat to the patient's vision is invisible from the outside: optic neuropathy. In this cross-section, congested recti muscles have nowhere to expand except inward, physically crushing the optic nerve at the narrow orbital apex. This compression strangles the nerve and blood supply, causing rapid central vision loss. Critically, this lethal compression can occur without severe outward bulging. Clinicians must actively hunt for optic neuropathy by checking for reduced visual acuity and looking for a relative afferent pupillary defect, even if the eye appears structurally stable. Surface redness tells us the phase of the disease, but tracking structural complications like optic neuropathy dictates the absolute urgency of our intervention. Treating TED requires matching the correct therapy to the exact biological phase of the disease. During phase 1, our goal is to halt the inflammatory cascade. For rapidly progressive, painful proptosis, we deploy systemic steroids and radiotherapy. We support this with conservative measures: topical anti-inflammatories, lubricants, eyelid taping, and elevating the head during sleep to drain periorbital edema. Phase 2 shifts our approach entirely. Surgical decompression is primarily reserved for the quiescent, fibrotic stage to correct cosmetically unacceptable proptosis, or utilized earlier only if steroids fail to protect the optic nerve. Orbital decompression physically forces more space into the system. Surgeons remove sections of bony walls and extract fat, allowing the globe to settle backward. If fibrotic tissue leaves the patient with restrictive myopathy and diplopia, strabismus surgery may be necessary, but only after the disease has fully quieted down. Utilizing active phase systemic steroids to fix a fibrotic mechanical complication is a clinical failure. The biological timeline strictly dictates the therapeutic weapon. If a patient presents with an expanding orbital mass but lacks the bilateral autoimmune hallmarks of TED, we shift the differential diagnosis toward primary orbital tumors. We split this differential by analyzing patient age, tempo, and anatomical location. First is embryonal sarcoma, the most common primary orbital malignancy in childhood, progressing rapidly. On a CT scan, it presents as a poorly defined mass, frequently destroying adjacent bony walls. Suspecting this tumor triggers an immediate protocol: prompt incisional biopsy, followed by systemic chemotherapy, specifically vincristine and actinomycin, and radiotherapy. We contrast that aggressive malignancy against a cavernous hemangioma. This is a benign vascular malformation that occurs in adults and expands very slowly over time. It has a highly specific footprint. While it can occur anywhere, it typically forms within the lateral part of the muscle cone, behind the globe. A CT scan will reveal a well-circumscribed oval lesion with slow contrast enhancement. Because it gradually enlarges, symptomatic lesions require direct surgical excision. Patient age and the spatial characteristics of the mass definitively split the diagnostic pathway between an aggressive systemic malignancy and a localized benign malformation. Returning to our initial case study, we have a 30-year-old female presenting with a 2-week onset of severe proptosis, reaching 24 millimeters, alongside red, starry eyes. Applying our diagnostic matrix resolves the dilemma. Her adult age effectively rules out embryonal sarcoma. The rapid 2-week onset, combined with acute epibulbar hyperemia, rules out a slow-growing cavernous hemangioma. The definitive diagnosis is clear. She is in the active, congestive stage of thyroid eye disease. Her management pathway requires immediate systemic immunomodulation with steroids to halt the inflammatory cascade. Surgical decompression will remain on reserve, deployed only if her optic nerve becomes compromised. Because the orbit is an unforgiving bony box, there is no margin for error. Mastering the strict timeline of a patient's symptoms, whether facing an autoimmune storm or a silent tumor, is the only way to accurately deconstruct the pathology and preserve their